Okay.
Okay, great. Can you see my screen?
Yes. Shall I give you a little bit of an introduction first?
Sure, I love that. Thank you.
Okay, great. Thank you, everybody, for coming to our symposium as part of the conductscience.org publishing platform. Today's symposium is entitled Leveraging Text-Based Outreach to Improve Enrollment in Federal Benefit Programs and Address Broadband Internet Access. This is Abhi Jain. He is one of the authors on the publication in question. Just to give everybody a quick description of the study. Essentially, as we all know, access to reliable internet is increasingly recognized as a super social determinant of health. Yet millions of low-income patients remain disconnected due to structural barriers. A solution to this is the Federal Lifeline program, which provides discounted broadband and phone services to low-income populations. In this seminar, Abhi from Rice University is presenting his team's findings from a study conducted with Linked Health, a Boston-based nonprofit dedicated to reducing health inequities by connecting underserved patients to social and economic resources. The team implemented a targeted text messaging campaign across the partner health community health centers in Massachusetts, reaching nearly 70,000 patients with information about the Lifeline federal program and assisted them in signing up for it. Among those contacted were 1,470 patients who engaged with the campaign, representing a racially, ethnically, and linguistically diverse population. He will be discussing the results of the study, the effectiveness of this scalable, low-cost digital outreach strategy for facilitating enrollment in social benefit programs, as well as its potential applications for other clinical contexts. Thank you, Abhi.
Great. Well, thank you so much for the introduction. I'm very excited to present this data today, and I think this represents a new and incoming and very innovative field in patient outreach. So very excited to take some time to talk about the field of text-based outreach to patients. So to start, I want to sort of frame this issue that we're trying to solve. And we call it oftentimes the digital divide. But I think it's really crucial to understand that this is not necessarily a technological inconvenience, a genuine public health crisis. Typically, when we consider the issue of internet access, we sort of think of it as separate to medicine, more so as a logistical failure. But I want to challenge that narrative and sort of promote this idea that the internet is as important as a social determinant of health as having access to nutritious foods or living in a food desert or not living in a food desert, and really just having access to health insurance. So in other words, internet access is a critical super social determinant of health, and that it impacts all other forms of healthcare that we know of. And so this is an issue that's particularly pronounced in the US. Around 10 to 12% of all Americans lack access to broadband internet. And while we do see how federal programs can exist to bridge this gap, they often face very significant structural barriers. And so really what we're trying to do here at Link Health is figure out how to solve that problem, to get patients connected to these programs in ways that in the past they were not able to do. I also want to present some interesting data about the impact in individual urban areas. And the issue does become a little bit more pronounced and catastrophic almost if we look at certain cities like Dallas, Houston, Boston. So the data here shows that in Dallas, for example, around 42% of households lack access to fixed internet connection. In Houston, which is where I am right now at Rice University, that number is around 17% or so. And then in Boston, it's somewhere between 20 and 25% of households lacking access to broadband internet. And of course, I'll note that the actual percentages will vary based on any given year. It fluctuates, and also on which organization, whether it's a governmental organization or a nonprofit, et cetera, who's actually collecting that data. But regardless of the actual number, it's pretty clear that huge swaths of the American population and really the global population are disconnected from the internet. And this can have a pretty tremendous impact on their healthcare, impacting really just millions of individuals. And really, I want to emphasize the impacts and the connection of internet access to healthcare. So the slide sort of goes through 5 of these reasons, and there are many, many more. But internet access is important because difficulties engaging with the healthcare system oftentimes follow from patients who are unable to connect to the internet. In other words, they aren't really able to schedule patient appointments with their doctors. They aren't able to head into these telehealth visits. They aren't able to communicate with the doctor's visits or doctor's office to cancel or begin a visit. So just really a number of issues are present when you don't have access to the internet. And a lot of these happen to do with the logistical aspect of healthcare too, right? Like filling prescriptions, et cetera. And it's not so much just a medical barrier, but there's also a social component here too. And that's what the last two represent, which is that there is tremendous disconnectivity from others when you don't have access to internet. There's disconnectivity from families, so that causes a huge mental health crisis. And then there's also disconnectivity from health information. So in other words, if you would like to learn more about a certain preventative form of treatments or care that may help in a certain disease, well, it becomes very difficult to gain access to that information, given how the entire world has moved towards a more digital form of care in the past decade. And so a lot of that information is now found online as opposed to text. And so it's very difficult to gain access to that information if you don't have access to the internet. So where there is a problem, there's also an opportunity. And this is where the Lifeline program comes in and what we do at Link Health. The Lifeline program, to give a quick rundown, is a federal program run by the US government, and it provides a $9.25 subsidy per month to get patients connected to the internet. Of course, there are some restrictions into like who can actually use this program. So those restrictions are, you have to have access, or you have to be a low-income patient. You have to perhaps qualify by having already pre-existing access to programs like SNAP, Medicaid, Medicare, et cetera. In other words, you have to fill out an application and show that you qualify. But it provides that subsidy to patients who do qualify in the end. And like I said, it is a program that's run by the US government, in particular, two organizations, the USAC, which stands for the Universal Service Administrative Company, and the FCC, which is the Federal Communications Commission. And it also works in conjunction with internet companies themselves. So with that said, we see how there is a problem and we see how there's a solution, but we also see how the problem exists and continues to exist because there are many patients who are unable to get connected to that solution, the Lifeline program. So where we come in at Link Health is figuring out how to bridge that divide, how to get patients connected to the internet and get them connected to these programs that already exist that they do not know about right now. And so our central question, our research question is, can a scalable, low-cost digital outreach strategy integrated with clinical care effectively connect patients to the Lifeline program? And this is sort of what we begin to investigate across our months of engagement with the program. And so we designed a study to understand this. And the study was done with 7 partner community health centers in Massachusetts, which reached around 70,000 patients. Importantly, we didn't focus on any patients. Rather, we focused on those who were considered adjunctively eligible. In other words, what that means is patients who were already known to be eligible for this program. So either they were considered low income and they met the necessary requirements there, or there were patients who were already on Medicaid or Medicare or SNAP, et cetera. So in other words, we reduced that barrier of having to verify if the patient would qualify. Rather, we were able to directly ensure and know that the patients who we were reaching out to would qualify for these programs. This was a 6-month engagement. We have done outreach beyond these 6 months, but the particular focus was on the Massachusetts community, which was done from June to December of 2024. Our intervention was built on a very simple four-step mechanism and workflow. The first step was really just the outreach that I mentioned. So our clinic partners would send an initial text about Lifeline with a link to these patients. The text message would include information about what the Lifeline program was, pretty briefly, and that link would then open up, when clicked, a new texting conversation, which would send them over to our team. And then that leads to step two, the actual engagement. So the patient clicks the link, that opens that pre-populated text, and it sends it over to us. And that leads us to step three, in which we can actually begin engaging with the patient. So we had these multilingual people who we call the ambassadors of Link Health ambassadors, and they would essentially work with the patients to first screen them and make sure that they do qualify for the program. But then after that, take their information and sign them up for the Lifeline program there and then. And then step four, once we get that information, we actually send it over to another team within the Link Health organization who actually is responsible for filling in that information on the governmental website, and then communicating back with the patient once that application is fully processed and approved, or if there are continuing problems with the application. For example, maybe you need more documentation for a certain verification of SNAP, et cetera, then they'll communicate with the patient regarding that. And throughout the process, we collected anonymized demographic data, including race, linguistic preferences, gender, as well as age, as well as their qualification method. So in other words, whether they're qualified via SNAP or Medicaid or Medicare, et cetera. And all the data was uploaded into a HIPAA-compliant Google Firebase dashboard. And importantly, the entire study was IRB approved. Like I said, we had around 70,000 patients who were reached, and among those who were reached, around 1,470 patients were engaged and assisted in signing up for the Lifeline program, and that led us to an engagement rate of roughly 2.15%. And so the end takeaway here is that the Link Health campaign represents a scalable model that can successfully engage thousands of patients, regardless of the fact that that 2% number may seem like a smaller number in the broader way of thinking about it or conceptualizing the number. However, I will also provide some data and look into another study that was conducted by another organization that shows that that 2% number really does align with our expectations. And so now I want to take some time to actually go a little bit deeper into who those 1,470 patients were. And in particular, I want to focus on the racial and ethnicity-based data. So we see that from this bar graph that around 41.84% of the patients we reached were Hispanic and Latino. So nearly 42%, or close to half of the patients we reached out to. And then the next highest was our white or Caucasian population. That was around 35.58%, or nearly a little bit over a third. And so I will also note that the Black and African American population was a little bit lower than expected, which was 10.61%. And we'll discuss these in broader context a little bit later. But I should note that the demographics we reached out to very much align with the demographics who tend to be the most underserved populations in the Boston area. So this does show that our program is effectively reaching the populations who would most benefit from this program and from the Lifeline program. I would also like to take some time to go through our linguistic or language-based data. We saw that there was a tremendous diversity in languages from the patients who we spoke with on our digital program. And this really does emphasize the importance of us having that multilingual team who was able to appropriately and quickly work with patients in a culturally competent manner to ensure that they were getting their needs met. So of course, around 2/3 of the patients we worked with were speaking English, or at least preferred English in their conversations with us. But around a third of those patients spoke Spanish. And that represents a very linguistically diverse population that we worked with, and goes to show how we were able to work with populations who, in many cases, are denied or not offered the same level of care because of their linguistic barriers. And there were around 5.10% of patients who spoke other languages. That includes languages like Arabic, Haitian Creole, Portuguese, etc. There were also diversity in sex, so around two-thirds, a little bit over two-thirds of the patients we reached out to were female, so 68.91% to be exact, and then 31.09% of those patients were male. And this more or less aligns with the types of patients that we reached out to in our original outreach. So we didn't see anything that stood out to us in terms of one sex working a little bit more with the Lifeline program and with Link Health and another. This more or less aligned with what we expected here. I also want to focus on our age-based data. I think there's a lot to say about our age range data that we have here. In particular, our largest demographic was the middle-aged or middle range age group, which was between 35 and 44 and 45 and 54. And both of those populations had a percentage of around 24.15% of our entire population we reached out to, or actually engaged with Link Health. And so they were clearly the majority, which also makes sense given the fact that the majority of our patients that we reached out to begin with were patients in this age demographic range. However, I also want to take some time to note that around 13.81% of the population of our patients we reached out to were 65 years of age and older. And I think this is particularly important to recognize because traditionally with many digital-based health platforms, they are thought to have barriers for certain demographics. And one of those demographics that is often thought to have a barrier is populations that are on the elderly side. But what our data shows is that we did not experience any sort of drop off from what was expected. Rather, we saw a large portion of our population coming from this demographic. So what this really shows to us is that our form of outreach via text-based outreach is very much capable of surpassing these barriers and age disparities to access to technological care. And so I think this presents a really great model in terms of working with these geriatric populations to present the best possible care for them. And also, I would note that we had a pretty even distribution across all age ranges. So we had around 10% of our population from the 18 to 24 demographic, et cetera. And the final piece of data I want to present here is data based on how our patients qualified. So like I mentioned, there are many ways to qualify for the Lifeline program. You can qualify based on income, you can qualify based on pre-existing enrollments and other programs like SNAP, Medicaid, Medicare, et cetera. And for the patients that we reached out to, like I mentioned earlier as well, these were all patients who were adjunctively eligible. So we all knew that they qualified for the Lifeline program, but we didn't just know like how they qualified. So we wanted to understand where there was overlap and where there wasn't overlap. And what we saw was there was quite a bit of overlap in these three programs, in these forms of qualification: Medicaid, Medicare, and SNAP. So around 41.16% of the population of the patients we worked with who qualified for Lifeline qualified via having Medicaid. Around 37.21% qualified by having Medicare, and around 64.97%, so the vast majority of them, qualified by having SNAP. And of course, those numbers add up to more than 100% just because patients may be enrolled in multiple of these programs. In fact, there were several patients who were enrolled in all three, or at least selected they were enrolled in all three. So now I want to go back to that point regarding the 2.15% engagement rate. And at first glance, it does seem like a low rate. But I do want to note that this is very much in line with what other studies have shown and have discovered from their own outreach campaigns. And so what the end takeaway here is that the model works and that it reaches the intended diverse underserved populations that we expected to see. In particular, I want to focus on one prior project that was pursued by the government, by the Center on Budget and Policy Priorities, in conjunction with the Benefits Data Trust. And what they did was an outreach campaign for WIC, So WIC just being another form of SNAP, and particularly focused on women, infants, and children, hence the acronym WIC. And in their outreach, they conducted that outreach across 4 states: Colorado, Massachusetts, Montana, and Virginia. And across these states, they saw that their texts were successfully delivered to around anywhere between 3/4 to 4/5 of the population who they worked with. But then, in terms of those who actually engaged with that, there was a huge drop off. And so, their version of analyzing success was basically those who request appointments to ensure that they're eligible for WIC and go through that sign up process. And so, looking across each of these 4 different states, we see that number hovers anywhere between 4% and 9% of outreach. And in Colorado, for example, 6%, Massachusetts, 4%, 6% from Montana, and 9% from Virginia. And that is specifically data on those who requested an appointment after receiving the text. So not just those who engaged with the text. So it does go to show that the number that we experienced of around 2% does sort of situate itself in line with what many other programs have shown. And in the paper, we also discuss other programs who have had other success with outreach to patients and have also seen that 2% number, or in range around 2%. Obviously, a key issue and problem with a lot of digital-based outreach is that it's expensive, and that it's oftentimes more expensive than in-person outreach, which is difficult to conceptualize. But I think it's also important to note that our outreach system really surpasses and bypasses those cost-based barriers. In other words, we present a cost-effective, scalable solution. In our outreach, we saw that for every single patient who we were able to get enrolled into Lifeline, or at least help enroll in Lifeline, that costed us anywhere between 5 and 15 cents. So in other words, this is a very low cost, and it's 5 and 15 cents in order to get them an impact of around $111 per year. And that's a one-time cost. So over a course of 5 years, that's half $1,000. Or just by under $1 worth of outreach. And so this really goes to show that governmental systems and other nonprofits should adopt text-based outreach because it is so cost-effective and has such a great bang for your buck, to put it into more colloquial terms. So now, looking a little bit more broadly in terms of who we reached out to and the impact that we had, I would say that our project very much was able to address health and inequity barriers. We saw that there was a high enrollment of patients from the Hispanic backgrounds, so around 41.8% of patients, and this aligns with our known broadband insecurity of this population in the Boston area. And in line with that, we see that our multilingual team and support system was very effective in working with these patients. Around 37.41% of the population were non-English speakers, including 32.31% being Spanish speakers. So it goes to show that our program was very much effective in working with linguistically diverse populations. And like I mentioned, to recap, we were able to address and surpass age-related barriers, engaging 13.81% of our population as 65 plus population. So I think these are important pieces of data to note that show that our project is very successful in engaging with those who've traditionally been denied healthcare or access to digital-based healthcare, and those who would most benefit from the Lifeline program. Of course, something that we discuss in the paper is an opportunity for improvement, which is that there was a lower than expected enrollment rate for Black and African American patients at around only 10.6% of the entire population. So this suggests that there is a greater amount of study that needs to be done to ensure that any sort of way in which we could have improved our program is analyzed. And we will continue to do that analysis over the coming months and look forward to ways to engage all populations as best as possible. So from here, what does this all mean? Like, what is the big picture? Our big picture here is that the healthcare system can and should use digital tools to address social determinants of health beyond the clinic walls. And this is a replicable model. Hopefully, our data that we present here, based on the number of patients we were able to reach out to, the demographics of those patients, as well as the cost to reach out to those patients, goes to show that this is a model that can be replicated across the country and even beyond that. Next steps is for Link Health to look into applying this model for other benefits programs such as food, housing, energy assistance, etc. We also want to conduct a quasi-experimental study with a control group to ensure that our program is the most effective way of reaching out to patients. And then we also want to continue to explore ways to improve our engagement, like I mentioned, to reach out to other minority groups and ensure that we're making the best possible impact that we can. And so I leave you with two takeaways. The first is that the internet access is a critical social determinant of health. As I mentioned earlier, internet access was often thought of to be something that was considered separate, disjointed from healthcare. But hopefully I've challenged that perception through this talk and through this seminar, that internet access very much is tied to having access to quality healthcare. The second takeaway, of course, being that text-based outreach model integrated with clinical care is a feasible, cost-effective, and scalable method of engaging with patients to support them in enrolling for essential benefit programs like the Lifeline program. So our work provides this roadmap for how healthcare can proactively reach out to patients and support them and support their well-being outside of traditional appointments in person. Lastly, I'd like to thank all those who have supported this project. So in particular, I want to thank the whole Link Health team and the A Healthier Democracy team as well. The CEO of A Healthier Democracy and Link Health, Dr. Alistair Martin, Ben Ruxin, Arshil Monsanto, as well as the entire digital team who is working with patients. So I would like to thank them as well as the text team who helped design our program. I would like to thank them as well as all others who were assisting with this project. So that concludes my talk, and I'd love to open it up to any questions.
I think Dr. He has a question, but he might need to send it in the chat. Let's see.
We appreciate it. Let me know if this works. So basically, really interesting study. I think this is certainly a very salient topic. One question is, when you're texting people, just to be clear, are these all the same, or are you adapting these messages for different cultural contexts or language contexts? Or what is the kind of strategy for outreach in terms of different language barriers?
Right. So when we first reach out to a patient, we have a message that is indicated in English and includes a message right after that, which says, like, if you speak another language, press, etc. And then there's that message is translated into other languages like Spanish, Portuguese, etc. So any patient who speaks Spanish will see, okay, to basically get connected with a multilingual Spanish-speaking navigator, all I need to do is send this message. And same for Portuguese-speaking patient, etc.
Oh yeah, we did something similar for international context between, I think, like the Ukrainian language, the Russian language, something for text outreach. We actually had to run it through a couple of clinical translators. So I'm wondering, like, did you kind of do the same, or was it just kind of like, how did you generate multiple language support for this?
Right. So a lot of it's the scripts that we use for texting patients are often very similar. So working with a given patient versus another patient in two different contexts often follows a very, very similar line. So we introduce the program, we introduce who we are, we introduce Link Health more broadly. We provide information on how to sign up. And so as a result of that, we don't really need to produce these very diverse, difficult to understand scripts. And so our navigators are able to use these scripts on a day-to-day basis. And so in terms of like getting access to a navigator in that moment, that is sort of mitigated because we have access to linguistically translated scripts for the navigators to use. Of course, when it gets to other languages, it becomes a little bit more difficult. But thankfully, we've also scheduled the navigators in a way that ensures that we have a Spanish-speaking navigator working at any given time, or a Portuguese-speaking navigator at any given time.
Awesome. Thank you.
Thank you, Abby. I guess my comments are, I guess in Conduct Science, we've done similar outreach programs. So when you say, oh, I've got this outreach percentage of only 2, it's actually very across the board. We understand that that's actually pretty typical, and we're always trying to find out ways to increase our engagement as well. So I was thinking about some of the populations you had expected more engagement from and how better to help them. And I suppose one theory I might have is I get a lot of spam texts, essentially. You know, I think we all do every day. So how do you kind of adapt your script to make patients feel like, okay, if I actually press this link, I'm not going to get a load of spyware or something on my phone? How do you kind of deal with that sort of potential problem?
Right. So I think there are 2 ways in which we address that problem, and it really tackles the 2 aspects or 2 ways in which that problem can arise. So the first, of course, is when the clinic sends a message to the patient, and the second is when we engage with the patient. One of the ways in which we've sort of bypassed that issue as much as possible is we actually have the clinic send the initial text message. And many of these patients are already very familiar with their clinic systems. They get text messages from them very often regarding their patient visits, regarding prescriptions, etc. And so these patients trust that number. And so when they see another text message coming from it, which says something about Link Health, some link to learn a little bit more, they are not as hesitant as a result. Of course, there's still significant drop-off. And something that we do discover from our outreach is that there are many patients who click that link to get connected to our team, but then there's also a drop-off. So not everyone who clicks it actually ends up sending the message back to us to get connected with our team. And so it's an issue that we're continuing to evolve on and look for more ways to increase the credibility of our work and our organization. But it is one that we have significantly addressed just by working with the clinics themselves and having them send that initial message. And then there's the second aspect to the question, which is sort of, when we're working side by side with the patient, Link Health is communicating with the patient, and they say, they pause and say, is it a scam, right? Should I really be sending this information to Link Health? And then it becomes a little bit more difficult, right? Because we have to move beyond the scripts to ensure that we have the patient's best interest in mind and ensure that we build that connection with the patient themselves. So we have to figure out how we build rapport with them beyond what we have on our scripts. And some of the ways in which we do that is by speaking a little bit more human to human and really trying to show what we do at Link Health as best as possible. Sometimes we provide a link to our website for them to learn more about it. We have a lot of significant press releases, so there's a lot to learn about what we do, and that helps with many patients. But of course, there's still going to be some who will put it off to the side and say, I still don't trust Link Health. And then at that point, it becomes really personal preference, and we can't do much about that, though we still want to continue working with these patients to ensure that we are able to provide care when they are receptive to it as well.
Mm-hmm. Have you considered also doing potentially an email campaign alongside the text as well, just for additional coverage every single place the patient will look, essentially?
Right. I think it's a great point. And it is something that we have considered in the past, doing a side-by-side email and text campaign. I think one of the reasons why we shied away from moving towards an email campaign was just because we didn't know for sure if all the patients that we were working with had emails. And
no, of course,
we were unsure.
Yeah.
Right. We were unsure if the hospital systems also had that information with them. I think many of them do, but I think for a significant number of the patients, they had phone numbers, but they did not have emails, or at least there were emails that they did not really check very often. So I think that could be definitely an area of research to look more into to see if email-based outreach has had success in other contexts. But just from our initial analysis, it was something that we moved a little bit away from just because we weren't sure if we would be able to reach the same number of patients as we would have just based on a text-based outreach.
Yeah, makes sense. Thank you.
Of course.
Does anyone else have any questions? Tony?
Yes. Hi. Thank you for that. I was just curious because since you have mentioned about the email outreach, so one of the biggest challenge, what do you think would be the biggest challenge to scaling this outreach more broadly, especially with communities that has, because still at this day and age, there would be some with digital literacy or limited rather digital literacy or internet access.
Right. So you're asking like, what is one of the barriers to this program in terms of scaling it beyond Link Health?
You scale that to those who has limited capacity.
Right. I think one of the major barriers that I see is sort of being able to maintain a level of person-to-person, human-to-human connection with the patients as we expand. I think it becomes very easy to sort of try to apply the model that we've used for our own outreach to other populations across the US. But it's very possible that those same populations may not have the same issues or the same sort of approach in thinking about digital healthcare as the populations that we've reached out to in our own outreach. And so I think one of the major barriers is thinking about how do we personalize or continue to personalize the outreach that we conduct to these populations. And I think you bring up a great point about digital literacy. A lot of the populations that we worked with had a certain level of digital literacy, but that doesn't necessarily mean that other populations across the US will have that same level or trust of digital systems and digital healthcare systems. So I think it's a great point and a great challenge that we have to continue to investigate a little bit further. I think I would continue to say that having teams at Link Health that are multilingual and culturally competent is so incredibly important to working with these populations, just because we want to ensure that the outreach that we are conducting is personalized and that it is done in a way that makes patients as comfortable as possible. So bringing in a team from a variety of backgrounds is something that has been so useful to us, and I think it's something that would be continue to be useful even as we expand.
Thank you. Does
Thank
anyone have any other questions?
Yeah, I just have a follow-up on that. Has there been any, surprising, or what has surprised you the most about how people respond to the text-based outreach?
Yeah, I think it's a great question as well. Going back to the original point about text-based outreach being considered as a scam, I think when I first got into this program, I was a little bit hesitant because I thought that text-based outreach would be something that many patients are hesitant about, just because I know, for speaking from personal experience, when I get texts that don't really seem relevant to me, I just delete them and mark them as spam and move on with my day. So I think seeing the level of engagement that we have seen has been really impressive and very surprising. And I think it does go to show that in this digital age, that text-based outreach has a lot of potential, and that we are moving away from an era where outreach must be conducted in person or via paper forms. Rather, it's moving into this era where we can work with patients, whether they are underserved or from one community or another community. We can work with them via digital means. So I think that's very surprising and also very uplifting.
Yeah.
Great. Thank you. Thank you so much again, Abby, for attending and giving us an insight into what you've been doing with your team.
Thank you very much for the opportunity. This was very exciting, and really excited to continue working on this work.
I think we have one more question from Kazim.
Hi, Abby. Can you hear me?
I can hear you. Yep.
Yeah. So there's some nice research you did there. I just wanted to know, how are you planning to make a control group, like you mentioned, in order to measure the true efficacy of your text outreach program?
Sure. So we actually have another component to Link Health, which is based on in-person outreach. And so Link Health as a whole is a massive organization that takes on multiple different forms of working with patients. So text-based outreach is just one of those ways. And so the quasi-experimental control group will be essentially done by analyzing that in-person outreach to see how that is comparable to digital text-based outreach, to see which is more effective based on the number of hours that we are working on that outreach, the number of months or time that we're spending, et cetera. So I think that will be incredibly interesting to look into. I think we can also look into it from a cost standpoint. So obviously I mentioned the 5 to 15 cents number, but looking at it from the cost of like how much does it cost to put someone in a clinic to work with patients, et cetera. So I think that would be our form of establishing that control group.
Great. Like, thank you.
Of course.
Is that all the questions for everybody? Okay, I think in that case, we'll let you go, Abby. Thank you so much for this. We'll be following up with recording. We will want to blast it everywhere to show your work everywhere, but thank you so much for taking the time today.
Wonderful. Well, thank you so much. Really appreciate it.
Thank you. Thank you, everybody, as well, for attending. I'll let you guys get back to your day. Stop recording.